Welcome, and thank you for joining us today for day 2 of our live virtual MDA Engage ALS Symposium. My name is Michelle Barrios, and I'm the Community Education Specialist at MDA. We are thrilled to have you join us today for this important educational symposium. Today's symposium is part of our larger MDA Engage Community Education series, which focuses on providing relevant and responsive information for the neuromuscular disease community from subject matter experts. Be sure to visit the MDA Engage section on mda.org for updates on virtual upcoming educational events. We would not be able to provide these educational programs without the support of our generous sponsors. I would like to thank Biogen, Cytokinetics, Mitsubishi Tanabe Pharma America, Apellis, Ionis, and Hillrom, now a part of Baxter, for supporting this ALS program. I would also like to thank their representatives who are in attendance today. Following the event, you will receive an email that will provide some additional educational materials from some of these companies, so be on the lookout for an email from MDA Engage at mdausa.org. Now, I have a few housekeeping items to go over before we begin day 2 of our symposium. We are recording today's event and will be posting it to the mda.org website for on-demand viewing to ensure that those who were not able to join us live today are able to access this information. Please know that all phone lines have been muted. We will be having a question and answer session at the end of each presentation. Please be sure to utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A bubble to open the window and enter your question. You do not need to wait until the Q&A session to chat in your questions. As questions come up along the presentation, please feel free to send those in. We encourage attendees to communicate with others by utilizing the chat feature throughout the day. If you want to say hi, share a bit of your story with others who are on the line, or have a question on something outside of the topics we will discuss today that you would like to obtain suggestions from the community, please use the chat feature. Simply click on the chat icon at the bottom of your screen and enter your comment to other attendees. Feel free to use this throughout the day to connect with others. You will notice on the agenda there are small breaks between some speakers. Please feel free to stay connected to the live broadcast during these times, but this will also allow you time to grab some water or a bite to eat throughout the day. You will also be able to log in and out throughout the broadcast. Finally, we will be sending out a brief survey at the end of today's symposium and would like to receive your feedback on what you've heard today. We strive to discuss topics that are of interest to you and use your feedback as a way to improve future educational events. So thank you in advance for taking the time to complete the survey post-event. With that, I would like to introduce our first speaker of the day. Dr. Kathy Lomen follows over 375 patients with ALS at the ALS Multidisciplinary Center at the University of California, San Francisco. Dr. Lomenhorth is also a full professor of neurology at UCSF and has significant experience in ALS clinical trials since joining the faculty after completing her neurology residency and EMG fellowship at UCSF in 1999. She is a member of NEALS and WALS and has received grants from NIH and ALS Association to study ALS predictors of prognosis, ALS environmental risk factors, imaging abnormalities in PLS and ALS, efficacy of intrathecal baclofen pump treatment for PLS, and also the overlap of ALS and frontotemporal dementia. Thank you, Dr. Lomenhorth, for being here today, and I will let you take it away. Let me just quickly share your presentation.
Thank you. While you're getting the slides up, I just want to thank you so much for inviting me to be a part of this symposium. We have a lot of really exciting information to share, and I just wanted to, as a way of introducing myself, just let you know about my own personal connection with ALS. There were 3 patients in my neighborhood growing up who had ALS, and so that was very impactful for me, and in part motivated me to go to medical school, study neurology, and then ultimately I worked with Dr. Richard Olney as my mentor to start the ALS Center at UCSF, and then he unfortunately developed ALS himself and passed away in 2012. So I have a lot of personal connection with ALS, and it's been my privilege to be able to work with patients and their families over the years, helping them through the process. So are the slides up now?
Yes, you are at the first slide.
Perfect. Okay, so you can go on to the next slide then. So this is just an overview for the talk today. I thought I would ask these particular questions. What do we know about ALS today? What drugs have worked in the past to treat ALS? A little bit about the platform trial, which you may or may not have heard about. And then talking about where do patients go to find out about clinical trials? MDA has an incredible tool that helps patients with that I will describe. We will talk about who should get genetic testing. What's the latest news about stem cell therapy? How can I get into an early access program to have access to some of these drugs and clinical trials? And then I'll just reemphasize at the end about where you go to find out about these trials. Next slide. And you can just click through the animations here. So what do we know today? We know that ALS is unfortunately universally fatal. The mean survival after first symptom is 3 to 5 years, but it's incredibly variable. Some patients I have had will die 2 months after their first symptom, and then I've had other patients who 10 years later are still walking fully. So it's very variable, and every person is unique. It's the most common adult onset motor neuron disease, and we do not understand what causes the disease, and that's what's made it so challenging to treat. It's also a very heterogeneous disease. Not every patient is the same. It varies in terms of where the disease starts, how it progresses, the degree to which people have upper and lower motor neuron involvement, which I'll explain in just a moment. And we don't have a biomarker to be able to diagnose the disease or reliably track progression of the disease. So let's go to the next slide. So ALS is a clinical diagnosis, and what that means is there's no blood test, there's no X-ray finding, we rely on the neurological exam. And so it's very important to be diagnosed in a specialized center, ideally that's certified by the Muscular Dystrophy Association, in order to make sure that ALS is what you have and that you don't have a mimic of ALS, because there's other things that can look like ALS. But in short, it's a combination of upper and lower motor neuron findings. So upper motor neuron findings meaning slow speech, a brisk gag or tapping on your jaw, a reflex, brisk limb reflexes, and spasticity or stiffness in the muscles. And then lower motor neurons findings are atrophy, twitching of the muscles or fasciculations, and weakness. And so it's this combination that's very unique for ALS, and of course when everything else is excluded, such as a structural problem or another diagnosis that can mimic ALS, such as Lyme's disease or B12 deficiency. The reason I show this slide is also to emphasize what is needed to be in a clinical trial. So in order to be in a clinical trial for ALS, you need to meet the classic criteria. And we can go to the next slide now, the Escorial Criteria. So you need to have both the upper motor neuron involvement as well as the lower motor neuron involvement. You need to have progressive spread of signs within a region or into other regions, and you need to have an absence of other diseases by EMG or imaging. So sometimes when we see people, they're too early. They maybe just have symptoms in one arm or one leg, and they haven't demonstrated progression over time, or they have only upper motor neuron damage or only lower motor neuron damage. And so that's why some of these patients need to be excluded from clinical trials until they start to progress, because as I was mentioning, the disease is really heterogeneous. And so we want to make sure that the patients who are in the study are going to be progressing at about the same rate. So someone with a pure upper motor neuron presentation or a pure lower motor neuron presentation often progress more slowly than the classical ALS case. So just want to emphasize again the importance of being seen, ideally in an MDA ALS center where the doctor has experience in seeing other patients with ALS, experience with looking for other things that look like ALS, just to make absolutely sure of the diagnosis. Eventually, we will be at a point where maybe there will be a blood test for ALS or something that we can detect on X-ray or on MRI, but for now, we are completely reliant upon the clinical neurological exam in order to diagnose ALS. Next slide. So there are published guidelines for exactly how to go through the process of making the diagnosis, breaking the news to patients, what treatments to start to slow the disease process, how to manage aspects of the disease like difficulty breathing, trouble swallowing, as well as treating symptoms that reduce quality of life. And this is all evidence-based. So these guidelines, which I have referenced on the bottom, and they're usually updated about every 10 years or so. These guidelines basically will list, here's the evidence that this particular treatment works, or here's the evidence that this other treatment works, or here's something that's used, but we don't have a lot of hard evidence for why it might be useful. And so it's really nice for doctors who care for ALS patients to be standardized in terms of when we recommend things like a feeding tube or breathing equipment. Next slide. I want to really emphasize there are a lot of treatable symptoms in ALS. So really, what I always tell patients, we're going to be treating you in 3 ways. We're going to treat the symptoms that bother you. We're going to help provide you with equipment to be able to optimize your functioning. And we're going to be giving you treatments to help slow down the rate that you're getting worse. And so what are these treatable symptoms that you can have treatments right now? Treatments that we have good treatments now to help mood and energy, to help with trying to slow that cognitive change that can sometimes happen. Pseudobulbar affect, which means easy laughing and crying. I'll come later to a drug that was approved in 2012 that literally can put that symptom in remission. Shoulder pain, difficulty breathing, having trouble with communication, too much saliva, trouble swallowing. We have treatments to help with these symptoms. Constipation, needing to go to the bathroom very frequently. Trouble with using your hands, we have equipment that can help with that. Or stiffness, we have medications that can relax the muscles, medications to help with cramping. So these are treatable symptoms that we have, that we can help patients feel better. Next slide. So I mentioned that ALS is very heterogeneous, meaning it's very variable with when it starts, how it spreads, the regions that are affected, whether or not someone has a family history of ALS or dementia. And so this is really important in thinking about clinical trials, because if you have too many patients in a placebo group, meaning they're not taking the active drug, who are really slowly progressive compared to the people that are in the treatment group, then you might miss an effect of a treatment. Or if you have patients that are very slowly progressive in the treatment group, then you might miss an effect, then you might show an effect that isn't really there. So it's very important to try to have in clinical trials groups that are balanced and patients that are fairly similar and progressing at a fairly linear rate. And so that's why in many cases, a lot of times patients are excluded if they're too early or too late in the disease process because they aren't progressing at that nice linear rate that's needed to try to look for the effectiveness of a medication. And so this categorization of patients is really important to make sure that we're not missing an effect of a drug or that we aren't seeing an effect that isn't really there. And then another key aspect of this disease heterogeneity is cognitive behavioral involvement. So about 50% of the time, ALS patients really have no changes that they notice with their cognition or their behavior. But in the other 50%, there can be very subtle changes. For example, a little bit of word finding trouble or subtle change in personality. Maybe someone that was quite outgoing is now a little bit more withdrawn, or someone that was more quiet is now more talkative. And of course, there are changes that are very expected with the disease in terms of if someone's not able to do some of their normal social activities or some of their normal work functioning, that can be challenging and hard, and people can definitely become depressed when that happens, and we have good treatments for that depression. And that's not what I'm talking about here. I'm more talking about changes that really aren't connected to the disease changing. So something like someone who normally didn't love sweets and ate more slowly suddenly is gouging sweets or shoving food into their mouth in a dangerous way that could lead to choking. That's an example of the type of behavior change that can sometimes occur if someone is having frontotemporal dementia. So I'm just going to go to the next slide for that to explain that. So I did research earlier on in my career looking at patients with frontotemporal dementia. It's a type of dementia. It's very different than Alzheimer's. Memory is fine, but patients have difficulty with word finding or personality changes. And what we found in studying these patients was that 30% of them actually had signs of ALS. And then turning the question around, looking at our ALS patients, we found that 50% had some sort of executive function deficits, trouble with making judgments, trouble with, like I said, just sort of these very subtle personality changes that we noticed. And so we realized that there seemed to be some sort of connection between these two diseases. And working with others at a way to kind of classify these patients, because like I said, for most patients, the changes are really subtle and really mild, so they really don't meet criteria for dementia. And so we came up with these 4 categories: classical ALS with no cognitive or behavioral problems, ALS patients with subtle cognitive or behavioral changes, and then ALS patients who had really full frontotemporal dementia, so a fairly significant dementia really affecting patients' functioning. For example, word finding trouble to the point that they really can't speak, even if their speech is normal, but just really can't get words out, for example, or very severe behavioral problems such that they're unable to live at home for safety reasons. And what's interesting about this overlap is that it tends to be, if someone is going to have some cognitive or behavioral changes or frank frontotemporal dementia, it tends to happen fairly early in the disease process. And we can certainly sometimes see development over time, but it's something that's often present at the very beginning. So not to worry you a lot about this, but what is exciting is that there is temporal dementia, one person might have these conditions. And the genetic cause in cases, or 70, which you've heard about. It's responsible for 40% of all familial ALS cases and 20% of FTD cases. And it's what's called a nucleotide repeat disease. So there's basically too much DNA that's in this gene, and it's causing it to be misread. And interestingly, even in patients without a family history, about 7% of cases of sporadic ALS and 6% of patients with sporadic FTD have mutations in this gene, the C9orf72 gene. So this was discovered in 2011, and we're literally just getting going with several clinical trials attacking this specific gene defect. So hopefully, exciting news soon for potential therapy for patients who have this particular gene mutation. And I'll come back later to talk a little more about why you might want to get tested. So the next slide, looking at environmental risk factors. I wanted to say a word about this, and you can just click through the animation. I wanted to talk about 2 things. One is chronic traumatic encephalopathy. It may be something you have heard of for decades. Dementia was known to be associated with boxing. Muhammad Ali has some issues with dementia and Parkinson's disease. And trauma, is just known to potentially cause patients to be more at risk for Alzheimer's disease, frontotemporal dementia, ALS. And the type of pathology that's found, there's something called TDP-43 and tau. There's basically proteins that indicate a commonality with these particular conditions when they're caused by a traumatic encephalopathy. And that pathology, the TDP-43, is very similar to what we actually see in all ALS patients, even those that don't have a risk of any kind of head trauma. Trauma-causing professions also are at risk. So soccer players are at greater risk for ALS. NFL players are actually 4 times more likely to ALS. And importantly, military veterans are twice as likely to get ALS. And it's higher in deployed versus non-deployed veterans. And so if you are a patient who is a veteran, or you are a patient who was previously an NFL football player, those organizations, the federal government and the NFL, compensate their patients with ALS so that they can have their care covered, that they can have their home remodeled, and they can have access to nursing care in the home. It's just incredible the type of support that the VA, the NFL are providing to patients who are thought to have gotten ALS in part as a consequence of their job. Obviously, a lot of people that serve in the military that do not have ALS, so it's not the only risk factor, but a lot of research is to understand this better and understand why these particular professions, why trauma is causing a risk for these various diseases, so that hopefully we can lead to prevention going forward. But if you are a veteran, definitely connect with the local VA and get registered, because you get a full pension, and there's just a lot of money that is given to veterans very appropriately, because they've risked their lives for our country, and then to have ALS as a potential consequence of that service is quite terrible. So I'm grateful that we now have funding from the government to help our patients who are veterans. And there are also many ALS centers, some VA ALS centers that are in VA hospitals as well. So something to keep in mind. Okay, next slide. Now let's get into what drugs have worked to treat ALS. So now we're going to get into the part of the talk where I'm talking about how do we slow things down. And so you can click through the animation here. This is a picture of a nerve and an axon, and there's just so many things that go wrong with ALS. So everything from toxic factors being released, aggregates being formed, problems with transport of factors along the axon, the part of the nerve, the longer part of the nerve, problems with supporting cells that are damaged. Within the cell, there's problems with how RNA is regulated, trouble with glutamate transport. All sorts of things are wrong. And the part that's made it really hard with ALS is understanding what's the trigger, what's the thing that's causing this whole cascade of problems to happen. And that's what we have not figured out yet. And so as a consequence, drugs that are being tested in clinical trials and the drugs that have been approved to treat ALS target all sorts of different mechanisms, just trying to find the magic bullet that's going to stop the cell from dying. And we have had some success in terms of slowing the rate that these cells are dying. And so on the next slide, I'd like to talk about 3 FDA-approved drugs for ALS. So even though we don't know what causes the disease, we think that it may be a convergence of multiple pathways. And so similar to HIV, where patients take a cocktail of drugs, all attacking different parts of the virus, it's possible that with ALS, we will need to take a cocktail of medications attacking different parts of the pathway to impact and help further the slowing of the disease. And so we have Riluzole, which is a glutamate antagonist that was FDA approved back in 1993 to treat ALS. And I'll show you that data in a moment. Nuedexta is an NMDA antagonist, which was FDA approved in 2011 for pseudobulbar affect, for easy laughing and crying, but also is thought to have a neuroprotective effect and many patients notice improvement of their speaking and swallowing when they take Nuedexta. So it can be worth trying, even if you don't have the problem of easy laughing and crying, to see if it helps your speaking or swallowing. And then Edaravone, a free radical scavenger, was FDA approved in 2017 to treat ALS. So I'd like to go through these 3 drugs before we get into some of the drugs being tested currently in experimental clinical trials. So Riluzole. This shows in green, so next slide, yeah, glutamate hypothesis. Riluzole is in green, and then the placebo is in white. And you can see a separation of the curves. This is survival. And so it's basically showing that patients who take Riluzole compared to placebo survive about 3 months longer than someone who does not. Now, a lot of people say, well, I don't necessarily care about living 3 months longer. I just want to be stronger now. And I think the way to think about Riluzole is that it works at every stage of the disease process. So early on in the disease, if you think about it being 3 months before you're going to have difficulty cutting your food, it would give you that 3-month benefit. Additionally, this particular drug was tested a long time ago when we weren't as strict about the types of patients we enrolled in the study. So patients were enrolled with more advanced disease. And I was mentioning that there's a period of time where the disease progresses more linearly and then kind of plateaus. And so if you have, if the patients aren't perfectly balanced between the placebo and the control group, then you can sometimes get situations where you can mask an effect of a drug. And so I think our hope is that patients taking it early in the disease process, that hopefully it may work even better than it did in this particular clinical trial. And then next slide. So I have to go over this scale in order to explain a little bit about the Nuedexta. So this is called the CNS-Lability Scale. And there's 7 questions about your ability to control your laughing and your crying. And what we found, and this was the scale that was used in the study to get the approval of Nuedexta, and what we find is that for people who score 13 or higher on this scale, that score correlates with a diagnosis of pseudobulbar affect, and many patients with that diagnosis benefit from this particular treatment. And so on the next slide, you can see the data of what Nuedexta does. So in black is the highest dose of the Nuedexta, and that's the dose that was approved. And then in gray is a slightly lower dose, and then in white is the placebo, so patients not taking any active drug. And this is how many days patients had trouble with easy laughing and crying. And you can see that that they were episode free, so no problems with easy laughing and crying. And so as you can see, the black bar and the gray bar look much better than the white bar as far as the number of days where they had no trouble with easy laughing and crying. And on the slide to the figure to the right, you can see that about 50% of patients went completely in remission on this drug, and from the symptom of easy laughing and crying, not from their ALS. So quite an exciting drug, and it really has quite a dramatic effect on this symptom, usually resolves it within a day or 2. Next slide. So the next scale I wanted to talk about to explain the next series of studies is the ALS Functional Rating Scale. Many of you who go to a multidisciplinary ALS clinic, an MD ALS clinic, have this scale tested every time you come in. The first 3 questions are around functioning above the neck, speaking, salivation, swallowing. The next 3 questions are around your hand function, around handwriting, cutting food, getting dressed. The next 3 questions are around leg functioning, how easy is it for you to turn in bed, to walk, to climb stairs. And then the next 3 questions are around shortness of breath, trouble lying flat, and whether or not you use breathing assistance. And this scale has been shown to be more accurate than any other measurement, more than breathing, more than testing physical strength, using a device to check grip. All of those measurements pale in comparison to this ALS functional rating scale as far as being most accurate at tracking progression over time. And what I like about it is that it's also one that really does impact quality of life, because if you're having trouble with many of these functions, then you're going to perhaps have more challenges with your quality of life unless we can do something to try to help support you in these functions. So it's the thing that's used as the primary endpoint for all ALS clinical trials. So I wanted to introduce that scale in talking about Edaravone or Radicava. So as I mentioned, Edaravone is a free radical scavenger, and initially it didn't look effective at treating ALS when all comers with ALS were tested. But for those who were earlier in their disease process, it did show a benefit of slowing by about 35%. It was done, and then it was confirmed in a larger study, but only in Japanese patients in Japan, so not a broader group. But the FDA in August of 2016 accepted this drug application and was considered for approved in June of 2017 and then released on the US market in August 2017. So this gives you a sense of the timeline of things. So once the FDA announces approval, even for this medication, which is more complicated and intravenous medication, it really just took 2 months to get into patients' arms. So that's quite exciting. And then another development that just happened last week, the FDA just approved an oral liquid form of Radicava. And this wasn't just tested in patients from Japan now. This was patients from all over the globe, making sure it was safe, looking to see if the slope of decline was about the same as in the treated group of the study, which it was, of the ALS Functional Rating Scale. And so with this approval, the company is estimating that it will be available for patients to actually start taking in June. So very soon, any of you who are taking the intravenous form of Radicava will have the option of taking this oral form. It can go in the PEG tube or you can swallow it. It's really very straightforward to take a teaspoon once a day. And so we're quite excited about this development because it can often be challenging for patients to get the IV formulation, go to an infusion center, or have a nurse coming into the home. And in many cases, insurance denies it because it's quite expensive. So this will certainly be more cost effective since it's an oral form. And of course, if you like the IV form, if that's working well for you and you have a good situation of being able to go to an infusion center or having a reliable nurse coming out to the home, then you have that option to continue. So no one will be forced to go to the oral, but I imagine for most new patients with ALS that they most likely would want to go to the oral form, which was shown to have the same blood level as the intravenous form. So quite exciting news there. And next slide, and then this just shows the change. So Edaravone group is in red, and then in blue is the placebo group. And what they did that was interesting for this study is they actually followed patients to make sure that they were all progressing at about the same rate in the placebo and in the treated group. And I thought that was really smart because then you could make sure that people were you truly had a good distribution between the placebo and the control as far placebo group and the treated group as far as the patients having similar clinical characteristics. And so the curves start to separate. And so keep in mind, less change is better, so that we're talking about change in this functional rating scale, which is on a scale of 48 points. And you can see that for the Edaravone treated group, patients did not change very much compared to the placebo group over time. And then there's some long-term follow-up there, I believe 6 months follow-up later at the far end point to the right. So basically, Radicava or Edaravone does slow down the disease process by about 35%. And then next slide. So now I'm going to just turn briefly to talk about the Centaur trial. This is the Amylyx drug that I'm sure many of you have heard about. It's a trial, it tests TUDCA, which is actually a synthetic derivative of bear bile, which was used in Chinese medicine for centuries to treat various ailments, and it's being found to have a purpose in treating a variety of diseases now, and one of them is ALS. And then they also combined it with sodium phenylbutyrate. So that was the drug that was being tested. And this timeline, this is from the Mass General website. They were Dr. Kutzkowitz was one of the investigators who initiated this studying this drug. And it just shows how long things can take. So it was February of 2013 where a couple of students found something, potentially exciting with this drug, and they founded the company Amylyx. And then you can see the slow process of testing the drug outside of patients, getting a grant to try to start, doing some safety studies, and then eventually doing a clinical trial in patients. And so today, where we are at today is we're just waiting for the an announcement of what the FDA has found in reviewing the clinical data to see if they will approve this drug. And that announcement will come on June 29th. So just about a month away, we will find out if this drug will be approved and give us a fourth approved drug to treat ALS. And the results looked quite exciting, very similar to Edaravone in that it slowed things down by about 35%, and then survival data showed improved survival by about 6 months. So I think quite an exciting potential drug. But a lot of my patients ask me, well, what do I do now? I don't want to wait. And so one idea that patients have done is to take TUDCA alone. So this is a study from 2016 showing that TUDCA alone may have some benefit. You can see the TUDCA patients shown in red and then the placebo patients shown in blue. And again, this is this functional rating scale looking at change over time. And you can see that the curve separates, suggesting that there's a decrease in around 35% of the amount of decline in patients on TUDCA versus the patients on placebo. This is available from Amazon or Walmart.com. I've not seen it available in the store, but it is available online. And the dose that was used in the trial was 1,000 milligrams twice a day. Now, one cautionary note is that the drug does cause things to move through your system a little more easily. And so rarely patients have had trouble with diarrhea. Now, a lot of ALS patients struggle with constipation anyway, and so many patients have found this to be something that helps to cure that symptom for them. So 1,000 milligrams twice a day, it is available on Amazon, and it is really extremely safe. The only side effect I've had patients have is a little bit of diarrhea in some cases, and so then they just go back to the lower dose, or some cases of patients feeling a bit of acid feeling in their stomach because it is a bile acid. So that's something you can do today if you would like. Next slide, I wanted to mention some new clinical trial guidelines. I was a part of a group that was determining guidelines for how do we need to think about designing and implementing ALS clinical trials. You saw from that previous slide that for the Centaur study, it literally took from 2013 till now to potentially get approval from the drug. And of course, we don't know what the FDA will say. They may say you need to go back and do another larger study. We have no idea what their ruling will be because the advisory group that looked at the data was split as far as whether or not approval was ready. They felt that the drug was ready for approval now versus needing a little bit more time to do more studies. So this particular group met, and it included patient input as well as other stakeholders, MDA, ALS Association. They were all there to help with thinking about these guidelines. And what came out of that was a recommendation to have trials be more patient-centric, involving patients more, trying to minimize the number of patients being on a placebo if at all possible, and trying to think about how to gain access for patients, how patients could get access to drugs when they don't qualify for a clinical trial. Many clinical trials have criteria where you can only have symptoms for 2 or 3 years before you can be in the study. And so sometimes people don't even come to medical attention and getting a formal diagnosis until after that time has passed. So there's a very limited window when patients are eligible to be a part of ALS clinical trials. And again, that was, like I mentioned, it was because of that reason you want patients to be fairly symmetric in terms of their rates of decline, and of course safe and able to participate in the trial, not to be too advanced and have difficulty, for example, swallowing a pill that needs to be taken orally, for example. So next slide. So here's how some of these guidelines have had an effect. So looking at the Courage ALS phase 3 study, which is a study that is happening right now with reldesemtiv. It's a fast skeletal muscle troponin activator, meaning it helps the muscle contract better. So it takes a muscle that's weak and helps it move better. It's an oral pill taken twice a day, and there's a 2-to-1 drug to placebo ratio. So meaning you have, two chances to get the drug as opposed to just one, a 1-to-1 ratio. And also, after 24 weeks in the study, everyone gets the active drug. And so I think it's a great study to consider being a part of, and we'll we'll get to that slide where it talks about how to find where trials are near you. But the goal is to recruit 550 patients, and it's sponsored by Cytokinetics, which I believe is one of the groups that's a part of the panel that's coming shortly. Next slide. So I mentioned in the beginning about platform. So this is another way to think about re-envisioning how we do clinical trials. This platform trial design has been used in cancer for years, but this is the first time that it's been used for ALS with the Healey study. There are so many companies focusing on ALS. There's at least 130 companies all working really hard to try to find therapies for ALS. So how do you choose what to test, and how do you make the trial happen quicker? We talked about this 10-year process that it took for Centaur. And I love this quote from a patient of mine with ALS, Sandy. She said, "I lost the privilege of working on the human time clock on January 6, 2018. The ALS clock is a lot faster." And so Sandy has worked very hard in advocacy as well to try to help accelerate clinical trial development and try to help with access to medications. So how do we do this? So the great thing about the platform study is that it's much cheaper and it's much faster. It can take 4 years as opposed to 10 years to go from start to finish evaluating a drug that may be effective. And so next slide. So this is the Healey platform design. This is from their website. You can just Google Healey ALS and you can download this brochure, which talks about how the trial works. So basically, there's a screening process, and then there are a whole bunch of regimens tested at once. So these different drugs are being tested at the same time and being compared to a shared placebo group. And that placebo group keeps growing over time as more patients are enrolled. So it's kind of this rolling process where drugs are slotted in, found if they're effective or not, and are removed, and then new drugs are brought on board. And meanwhile, this placebo group keeps growing. There's a 3-to-1 randomization. So that means you have 3 times more likely of a chance to get drug as compared to placebo. And the study has been going so well, they've already completed these 4 drugs that are shown in this slide, and patients are on open label extension, and the drugs are being assessed as to whether or not they're effective. And so next slide. So the current drug that is enrolling for patients is I think one of the most exciting drugs that has been tested for ALS to date, and that's Trehalose. And what the drug is, it activates autophagy. And so to explain what autophagy is, if you think back to that original slide that I showed you with the cell and all the things that were going wrong and these clumps of protein that were aggregated, Trehalose works to break up those clumps of abnormal proteins and get rid of them. So basically, it's like cleaning house. It's getting rid of these damaged clumps of proteins that are clogging up the cell and causing the cell to die, and helps it to function more smoothly. So I'm very excited about that mechanism. It's an intravenous drug, so you would have to go into the study site for 4 times, and then you can do home infusion after that. Really would encourage you to consider that. And then I just wanted to say a word just about non-medicine types of trials, but trials that are quite exciting, and that is thinking about how can we communicate with our brain waves. And there's 2 different studies, one at UCSF, one at Stanford currently, that are doing some very exciting work to try to be able to speak, just thinking your thoughts, and then also robotics, so using a robotic arm to be able to do tasks. And I have a patient who's participated in these studies and was showing me on video how she could use her robotic arm, even though she's paralyzed, to feed her dog. So that's more to come, but a lot of technology advances are going to make things quite exciting for patients to have more mobility, even when and independence, even when they've lost their strength in their arms and in their legs. So next slide, let's talk about how to find a clinical trial. Most important slide in my talk. I absolutely loved the MDA Clinical Trial Finder. And so you can find that on the MDA website. I have the links here. You can just Google, if you want to find an MDA ALS center, if you're not connected with one, you just can Google that, and this link will pop up, and you just put in your state, and it lists all the different centers near you and how to contact them to make an appointment. The clinical trial finder, you basically go and you put in information about yourself. What's your age? When did your symptoms start? Where do you live? How far would you be willing to travel for a clinical trial? And then it tells you everything that's available to you, and then you can research those more fully. The most comprehensive site for all clinical trials for all diseases is clinicaltrials.gov, and there you can type in your disease, and you can type in a specific trial if you know of the name of the trial, or if you just want to search all the trials, you can click on various filters, and you can say, I want just current trials in California, for example, and then it will show you what current trials are happening for ALS in California. So these links are just very, very important and make things very accessible for patients. Next slide. So I mentioned about genetic testing briefly, and I mentioned how even in patients that don't have a family history, that they can have a gene abnormality that is thought to cause ALS. And so in thinking about the testing, we think whether you should have it done, think about would it change your management? You know, are there new treatments or clinical trials? And right now that answer is yes. There are clinical trials for C9orf72. There have been various trials for SOD1 and other mutation. So I would say yes, it is worth considering getting testing to see if you could be in a clinical trial that has a very targeted focus on a genetic cause. If other people in the family with similar symptoms have already been tested, then that can be an easy thing because then you just need to get tested for that one particular gene that's causing the disease. You can think about, is there a current clinical trial where testing may be free? I'm going to come to the testing for the main drugs, main genes, but let's say there was some very rare gene that was being tested. Maybe they would be doing it for free to be able to recruit patients for their study. Sometimes patients think about testing if they're thinking about having children and if prenatal testing is available. We think about coverage, and I'm going to come to that in the next slide, how that is free for all patients with ALS right now. And then thinking about genetic counseling, there can always be implications of getting genetic testing and understanding the results, so genetic counseling can be very valuable. So next slide. So right now, for every patient with ALS, regardless of whether you have a history, a family history of ALS or not, it's free. And that's thanks to Biogen partnering with Invitae to provide this free testing. And it's very easy. Either blood or saliva can be sent in. Your doctor can order the test on, there's just an online form. It's very, very easy and straightforward and quite exciting because now so many patients have really been curious and have wanted to get genetic testing, and now it is available for everyone for free. So just ask your doctor about that. Next slide. I promised at the beginning to give a quick stem cell update. I think Neurone Brainstorm, which many have heard about, it was quite exciting because of the phase 2 results being quite promising. Basically, cells are removed from a patient, modified to produce growth factors at higher levels, and then put back into the spinal fluid. And then this happened like every 8 weeks. And results suggested that there might be some small reductions in the rate of the disease, but unfortunately the phase 3 trial results did not reach their primary endpoint. And this was recently published, but I think it's still thought to potentially be helpful maybe for patients with really rapidly progressive disease. There was an early access program that was available for people who were participants in the study. And so that provided patients an opportunity, if they were in the study and felt like they benefited from the treatment, to get a few more treatments with stem cells. But I think that for now, there are a variety of stem cell trials happening around the country, but nothing that has been approved right now. And I do not recommend getting stem cells through any other way except through a clinical trial right now, because it can be quite dangerous. Next slide. I'm going to skip this since I'm running short on time. This shows the effect of the promising phase 2 results that made the company move forward to phase 3, showing a benefit, particularly in those patients progressing more quickly. So EAP, I wanted to say a word about that, early access program. So there are various steps that are needed. The drug company needs to be willing to provide the drug. There needs to be FDA and IRB approval, which is accelerated for ALS. The Act for ALS, which you may have heard about, was approved by Congress and provided a lot of, this provided a lot of funding for early access for ALS, but the funding has not been appropriated yet. So I think we're hoping that this summer funding would be appropriated, and then more patients can have early access to some of these exciting therapies. But for today, that program is not funded, and so there's really limited early access slots available in some of the various clinical trials that are happening. Next slide. Almost done here, and then we'll open up to questions. I just really want to caution about alternative therapies for ALS. So that you will find you can get stem cells. You absolutely can get stem cells. There are options in the US and other countries. They're quite expensive, and I have had patients die. So it is just really, I would encourage you to be very, very careful. You have no idea what is being injected. These are therapies not regulated by the FDA or any other regulatory body. So I would highly encourage you not to do this. We know that just injecting stem cells randomly into the blood or in the spinal fluid without any kind of modification is not going to work. Umbilical cord blood does not work. So I think eventually stem cells will potentially be an exciting option for ALS, but we're just not there yet. So I would encourage you to be a part of a stem cell trial if there's one happening near you, but I would not do it on your own. Be careful with supplements. Some supplements can cause nerve damage if you take them in excess. So just really follow the labels on the bottles and don't overdo it. Detoxification programs can also be harmful. Things like, or I've had patients who've had all their teeth removed or who have undergone these chelation type programs, and I have not seen it help, and I've definitely seen it hurt because people can get quite sick from it. Unusual diets oftentimes can cause harm if they cause rapid weight loss, which can be bad for ALS because people often lose muscle. And then lastly, you have to be careful taking clinical trial medications off label. In a clinical trial, patients are followed really carefully, their blood's monitored, and there are often significant side effects. So if you are interested in trying a medication off label, getting it from overseas or something, just talk with your doctor, make sure that you're having the same type of monitoring that would be used in a study and that you're taking the same types of doses that are used in the study. I love alsuntangled.com. It really looks at all of the popular types of therapies you'll see on the web about, oh, I tried this and it cured my ALS. And it really can sort through and weed out what therapies are harmful, what therapies may have some potential benefit, but just haven't been studied enough. Next slide. So in this is just my second to last slide. I just wanted to, summarize where we're at. I think that a lot has happened with ALS, particularly in the last 10 years. We now have 3 drugs to treat ALS, including an oral form of Radicava that's just coming out, and then potentially on June 29th, when the Amylyx trial result is announced, maybe we'll have a 4th drug to treat the disease. I would really encourage you to go to the MDA website and try that clinical trial finder, get connected with an ALS multidisciplinary clinic that's sponsored by the MDA. Multidisciplinary care alone and some of the therapies like non-invasive ventilation can prolong life by over a year and can really help with quality of life. So that's something that everyone can do now. And then think about getting the free genetic testing, be very cautious in thinking about getting stem cell therapy, and keep your ears peeled for that appropriation of funding for that Act for ALS so that hopefully more patients can have early access. So next slide. So I just want to acknowledge my ALS team. This is us doing the Ice Bucket Challenge in an era where we didn't have to wear masks. And so just want to thank everyone that I work with and open it up for questions. So thank you for having me today.
Thank you, Dr. Lomen. Some questions have already come in throughout your presentation. The first question that came in was oral Edaravone. Was it compared to a placebo or just to IV or neither?
Neither. So what they did is we had data on what's called the bioavailability of the IV form of Radicava. And this oral form met those exact bioavailability standards. So basically the blood levels that you get when you take the oral is exactly the same as when you take it IV. and it was, and then also the patients were followed to make sure that their rate of decline was similar to the study that had been done. So while we don't directly know how whether it would show the exact results of the study, at least it seems to be within the same ballpark. So I would say there really shouldn't be a reason to take the IV form anymore unless you really want to. But great question.
Another question that has come in is, TUDCA the secret sauce and phenylbutyrate just added so they can charge for it. Do they know how TUDCA works alone relative to AM00035?
Yeah, that's another great question, and we really don't know. I know in Europe there's a large study of TUDCA that's ongoing, and I think the only way we'll know for sure how important the sodium phenylbutyrate is to this cocktail is when we would get those results of the trial from Europe. But I think that based on that full study I showed, I think it's likely that the TUDCA at least has some effect, and so I would encourage you to take it while we're waiting to hear the trial results.
Another question, is oral Trelos effective or only IV? If oral could have some
only
impact.
IV. Yeah, unfortunately, yeah, because the Trehalose, you can buy Trehalose, but yeah, no, it's just not, you can't get the doses, I guess, high enough, or it's not as stable. So yeah, it doesn't, unfortunately, it has to be IV in order to have its effect.
Alrighty, I have one more question. If you have any other questions before the end of this presentation, please feel free to add them into the Q&A or the chat. Either one would work. The last question I have here is, familiar with, and I'm going to spell this out because I'm not sure if I'm going to be able to pronounce it right, ZHITTYA and angiogenesis.
Did you say D as in dog, HITTYA?
Z as in zebra. So Z as in zebra.
ZHITTYA.
Yes.
And angiogenesis.
Yes.
I mean, I think it's basically a type of growth factor, and so I mean certainly I can see that there is some literature about it. I'm not aware of it being tested in ALS specifically. There was another drug that did help promote angiogenesis that was tested in ALS that did not work, but I think it's being tested in other conditions. So. Anyway, so yeah, I guess more to come, but yeah, I personally have not, I'm not familiar with that particular drug. But keep an eye on clinicaltrials.gov, and then it should tell you if there will be a trial coming out for ALS.
Well, I do not see any more questions, so I would like to thank our first speaker of the day, Dr. Lomen Hoerth. Thank you so much for your time today, and thank you for all that you do for the ALS community. Thank you so much.
Thank you. Appreciate everyone's great questions. Have a good day.
Thank you.